CA.
CA, yep, very good. So CA is for several reasons. So first of all, as you may have read or know, that about a third of adenocarcinomas from the lung, so primary lung cancers that are adenocarcinomas, a third of them will produce sort of CA. So they will have elevated CA, say 15, 20, and the more advanced the stage, the higher the CA, very much mimicking other CA related tumors in the GI tract. But there's also the 2/3 of adenocarcinoma of the lung that don't relate to CEA, in which case it is not as useful. But also elevated CEA may indicate that the patient has another malignancy somewhere else in the GI tract, most notably in the colon. And this lesion can still be a primary lung, but it can also be a metastasis from a GI tract tumor. So an elevated CEA will prompt you to look deeper into whether this is a CEA secreting primary lung cancer, but also you need to look further afield to see whether it's a double primary or whether this is actually a metastasis from a colonic adenocarcinoma, for example. Okay. But a normal CEA does not exclude lung cancer for the reason I just described. We will, of course, do the other bloods to see if they are potential, if they have any other diseases or surgical candidate, if they have, really poor organ function elsewhere. Sometimes liver metastasis will provide a slightly abnormal liver function test that may trigger something for you to investigate the liver. You may not have examined the liver in your first outpatient clinic, but with the liver function test coming back as abnormal, you may decide to go and palpate the liver, in which case you may find a large craggy edge liver that may suggest a metastasis from either the colon or from the lung, if you see what I'm saying. Also, we want to look at, whether the patient has anemia, stuff like that, which may indicate the patient has colon cancer, or if they don't, if they have anemia, it is a prognostic marker for poor outcome in lung cancer. So someone with anemia in stage 1 lung cancer versus someone who don't have anemia with stage 1 lung cancer, given the same treatment, the one who doesn't have anemia will have a better 5-year survival. The exact mechanism is unknown, but there's a lot of data that suggests that is a prognostic factor as well. So you would do those, of course, and then the next thing that you would arrange for a patient with a suspected lesion would be imaging. So what would be the next basic imaging that you would request after a chest X-ray? Yep, contrast CT scan. So I like that. So I like the contrast. That's half a mark, and a CT scan is CT thorax is the other half of the mark. So you get your full mark. Unless the patient has allergy, to contrast, or has severe renal impairment, or have other diseases that don't allow them to have contrast, we would normally order IV contrast CT thorax. The reason for that are several. One is that it shows up the blood vessels that are feeding the tumor. So a benign tumor will have very little blood supply going to the lesion. For example, a hematoma, which is a benign tumor of the lung, will almost have no contrast enhancement when you do a CT scan before you give the contrast and after you give the contrast. And that helps the radiologist differentiate a more benign with a malignant lesion. Malignant lesions tend to have more blood supply. The other thing is that when you have a lesion, may not apply to this particular lesion, which is more peripheral, but when you have a lesion which is close to the mediastinum, close to hilar vessels and hilar structures, when you give contrast, those vessels will show up better, and you'll be able to see if the tumor is encasing the blood vessel or has invaded the blood vessel more clearly. Yeah. The third thing really is when you give contrast, another structure shows up, which are lymph nodes in the mediastinum. So the density of the lymph nodes in the mediastinum are very similar to the density of the fat in the mediastinum. So if you don't give contrast, your CT scan, your CT thorax, the fat structures in the mediastinum and the lymph nodes will just be the same gray color. But as you remember from your histopathology days, the lymph nodes have their own blood supply that go into the hilar of the lymph node together with lymphatic vessels. So after you give contrast, actually the lymph node will enhance and be differentiated from fat structures, adipose tissue in the mediastinum. And then you'll be able to see whether the lymph nodes are enlarged, which may suggest that they're involved in the tumor, in metastasize to the lymph node, if they are craggy looking, and so on and so forth. So you have a visualization of the lymph node size and with the IV contrast. So it's important to give contrast if the patient has no contraindication. Okay, so after you do a CT thorax with contrast, for example, the report says that there are no other lesions within the chest, just this 2 centimeter left upper lobe spiculated mass here, and seems no other involvement. How would you proceed next in terms of managing this lesion, assuming that the CEA is negative, assuming that all the cytology from the sputum is negative?
Biopsy?
Yep, so biopsy. So can you tell me the 2 commonest ways to do a biopsy? Which you might be asking.
Guided or image guided, like CT guided biopsy?
Yep, CT guided and image guided, I would consider that as one type, which is to basically stick a needle from the outside through the skin and the chest wall to aspirate some cells. And what's the other type that goes through?
Route.
Yeah, bronchoscopic biopsy. Okay, so you're quite right. So this patient actually had so let me just show you the CT scan. Are you able to see this or not, the CT?
No, it's still the chest X-ray.
Okay, that's not good. Why is that? What's happening? Okay, now that should be better. So this is the lesion. You should be able to see this now in the left upper lobe. It's quite peripheral. It doesn't involve the chest wall. It's quite solid and quite spiculated, so it looks quite nasty, and there's a little bit of ground glass change adjacent to it. So when you are looking at a lesion, how to biopsy it, you really need to put yourself in the shoes of the bronchoscopist and put yourself in the shoes of the radiologists who do the CT-FNA or the image-guided FNA. So for this particular lesion, for image-guided FNA, essentially you need to pass a needle either from here to hit the lesion. Okay, so this is the scapula. So the radiologist can't go through the bone. Okay, so they have to put it through here, which is possible, or they put it through here, or potentially a shot from this side between the rib space here to get to this lesion. Now, this lesion is large enough to do a CT-guided FNA because it's like above 1 centimeter. Most radiologists are comfortable in doing a CT-guided FNA if the lesion is 1 centimeter or above. Why not less than 1 centimeter? Because the hit rate will be much less. So they will start skimming the edge of the lesion because the needle will have to be very accurate if they're trying to hit a 1 centimeter or smaller nodule. And there's quite a way to travel in most patients. And, if you have to stick in the needle 6 or 7 centimeters, a little bit off trajectory means that you'll miss a 1 centimeter nodule. So this is about 2 centimeters, so it should be okay. So it's reachable, but there are complications associated with percutaneous biopsy, which I'll go through in a minute, because you might be asked in a communication short case, to consent a patient, maybe something that can happen. From a bronchoscopic point of view, you want lesions that are relatively reachable by these kind of airways. So lesions that are in the sort of middle 1/3, I guess, of the lung. But when you're reaching the middle third or the outer third of the lung, then you start running into trouble, because first of all, you might get lost with your bronchoscope with the branching of the airway as you go down the second, third, fourth generation airway towards the middle third or the outer third of the lung. Secondly, you're going to be using narrower bronchoscopes if you want to reach these areas, because the airways get smaller. So the tools that you're able to use will be less effective in getting your biopsy, and you won't be able to get as good a view. So essentially, most of the bronchoscopic biopsies are done in the central third of the lung, where you can use a larger bronchoscope, where you can, see what you're doing and so on, and you don't get lost. So the risks of flexible bronchoscopy are very relatively few. You can potentially, if you're really crazy about how you're doing it, still create a pneumothorax by passing a very sharp tool very, extensively deep into the lung. But it's much less likely than a percutaneous approach in terms of pneumothorax. So you can get airway spasm. You can trigger a COAD exacerbation by putting a scope down there. You can potentially get respiratory failure by occupying the major trachea by a bronchoscope, so that the patient has difficulty breathing during procedure and desaturation and so on. But those are essentially the things, and bleeding and hemoptysis, I guess, would be the other potential complications of bronchoscopy. But they are relatively rare in terms of serious complications that happen during bronchoscopy, and so on. For percutaneous, if you have to consent a patient for percutaneous biopsy, then essentially you need to tell them the risk of pneumothorax. The risk of pneumothorax will, of course, depend on the quality of the lung of the patient. If they are elderly, if they have been smoking a lot, if they have lots of emphysema in their lungs, then the risk of pneumothorax will be much higher. In general, we see about pneumothorax in 30 or 40% of our patients after a CT-guided FNA. And not all of them require intervention. So out of the 30 or 40%, many of them just have a repeat chest X-ray to show that the small pneumothorax has not increased, and we're able to just let them go home with a repeat X-ray. But in probably 10% of patients, we do need to put in a chest drain to drain the pneumothorax that's getting larger with serial chest X-rays after the procedure. Apart from pneumothorax, there's also the potential risk of hemothorax if you hit a large vessel and it bleeds, or bleeding into the lung. And there's also some pain of the large needle going through the chest wall, and potentially injuring the intercostal vessels as well. That's between the ribs that the needle needs to go through. Okay. As with both biopsy methods, you may get a false negative if you just skim the edge of the lesion or don't actually get enough tissue that you need to consent the patient for. Okay. And some other rarer complications. Okay. So for CTFNA, can anyone think of rarer complications for CTFNA apart from pneumothorax, hemothorax, when you stick a needle into the lesion?
Needle tract seeding.
Yeah, very good. Needle tract seeding. So it's reported to be like really rare, like 1 in 1,000, 1 in 2,000, or even. So it does happen. I mean, I actually, to be honest, often we don't consent the patient for that because it's so rare. But if patient asks, it's a value that you can give them, and you say there is a risk, but say 1 in 2,000 or something like that can happen. So that's a possibility. And then a even rarer complication that probably you may not be aware of or heard of. It's complicated. Yeah, well done. So air embolism. So do you know how that occurs? So that's really occurs when a needle, the needle track from the outside, manages to go through an airway like this and a vessel, and it communicates an airway with a blood vessel. And when that happens, in very exceptional and rare circumstances, air will continue to trickle into the vessel. And of course, if that vessel is a pulmonary vein that goes back into the heart, then it will go into the left atrium, left ventricle, and the air may accumulate in the left ventricle to cause, heart failure, pump failure. But normally, worse still is that the air will go into the coronary vessels as air embolus to the heart. So of course, air can go into the brain and cause stroke and stuff like that. But probably the thing that caused the cardiac arrest would be air going into the coronary vessels that come off the root of the aorta, as you know. So it's a event that happens maybe, if you're very lucky in a lifetime as an interventional radiologist, it will not happen to you. But if you're unlucky, then it will happen to you once or twice in your lifetime as an interventional radiologist, doing this kind of procedure day in and day out. So it's very rare, exceptionally rare, but it does happen. Interestingly, again, we, tend not to necessarily consent the patient and scare them to death about this kind of complication. But with a unexplained sudden hypotension plus ECG changes in a patient, something that you need to think about, particularly for those who are going into radiology as a specialty. So there we are. So the pros and cons of each, and where you expect the lesion to be to do your biopsy. What else I want to say? So image guided biopsy, the other imaging modality that sometimes can be used is ultrasound guided. Okay. It's rarely that we'll do MRI guided, because you'll do a CT guided instead, which is much cheaper. But with ultrasound guided, why we would order that sometimes is that we get an appointment much quicker than a CT guided FNA. And which are those patients who are suitable for ultrasound guided FNA are those who have a larger lesion that is completely abutting the chest wall. So the ultrasound, as you know, when it's used on the outside of the chest wall, will deliver the echo shadow towards the lesion. But if the lesion has a air interface like this one, even if it's a small air interface, then the ultrasound will not function normally. So the deflection won't occur. So the lesion will have to be touching the chest wall, at least in a reasonable area, for the ultrasound to see that lesion and be able to guide a needle directly into the lesion. I hope that makes sense to you. Okay, so this is not possible because there's an air interface here, and ultrasound is not possible. Okay, any questions so far? Happy? Okay. And there are some newer forms of ways that we can do biopsy. For example, you may have heard like electromagnetic navigation bronchoscopy that has like a GPS system. It's not GPS, it's electromagnetically guided, that of course takes the bronchoscope to distal parts of the lung. And I've talked about that, and I won't go into that anymore because I've discussed that in my tutorials previously. Okay. So this lesion can be biopsied using a navigational bronchoscopy platform as well. So this patient had, let me just get next imaging out. Okay, so you probably can't see the next imaging, so let me share again. All right. So now hopefully you should see the CTFNA needle. Okay. So the lesion has come over to the other side. It was on this side, wasn't it? But this is actually the same size, the left side, because the patient is now lying on the front. Is lying prone. Okay. Because the approach that the radiologist has decided upon is entering the back wall, the posterior wall of the patient to hit this particular lesion. The scapula is here. So that's why the aortic arch is on this side. And there's a little bit of pneumothorax you can see here, which does happen. Okay. So after this biopsy, with any luck, of course, we'll be able to know the diagnosis. So assuming this is a diagnosis of a non-small cell lung carcinoma, which is most likely an adenocarcinoma on the pathology report, what would you be looking into next in your investigation? An imaging modality that helps you stage.
EBUS.
Yep. PET-CT, yep. Someone said PET-CT, yep. So you're not wrong to say EBUS, in fact. And I'll explain why you're not wrong to say EBUS as the next step. But usually, often we would go for an investigation that it goes from the least invasive to the more invasive. So although EBUS is not, doesn't involve surgical scars and is not that invasive, often we would go for a PET-CT first before we go for EBUS. But some places do go for EBUS first, so you're not wrong to say that. So for lung cancer, in fact, it's one of the cancers that we would order PET-CT for everybody. When you do general surgery or other kind of specialty, there will be tumors that they're just happy with a CT scan and then to operate. For example, colon cancers, quite often we see a PET scan after they've done the operation. Sometimes the argument being that the lesion is very small, it's unlikely to have metastasized, so they're just going to go in and do the operation first. Sometimes because the colon cancer is causing some symptoms, some obstructive symptoms, so they argue that we just need to relieve the symptoms anyway, so let's do the surgery first, and then do the PET-CT like after the surgery, and then they might find metastasis elsewhere in the lung or whatever, and that get referred to us. But lung cancer, primary lung cancer, we would order PET-CT as a matter of guideline because a lot of lung cancers metastasize early. In fact, about 70 or 80% of newly diagnosed lung cancer are not in the early stage and are not surgically resectable. So most of them actually go to oncology for the very reason that I described. And of course, depending on the cancer type, if you're looking at small cell lung cancer, then is even a higher rate of early metastasis than non-small cell lung cancer, as you know. So this is a kind of a PET scan image that you get. Of course, PET is a fusion image between the PET and the CT scan. And you can see this active nodule here that corresponds to the CT earlier on. So the areas that this PET-CT will help us look for metastasis and stage the patient, essentially. So two areas that we're interested in. One is the lymph nodes in the mediastinum, essentially, which is usually the first area that the lung cancer metastasize to from a lymphatic route. So they go to the hilar lymph nodes and then to the mediastinal lymph nodes, and then potentially to the N3 lymph nodes in the neck, and so on. And the other area that we look at are for distant metastasis. So you might be asked in multiple choice what are the classical organs that lung cancer metastasize to. So I think one of your classmates already said, I said the bones already. So bone is one. And anyone? for the other 4 areas that classically metastasize to lung cancer?
Brain.
Brain, yep. Adrenal, very good. Breast, not usually. Although breast metastasize to lung, but not the other way around. Okay. So adrenal, brain, bone, 2 more. Liver, yes, very good. And one which is like a trick. Yeah, contralateral lung, yeah, or other parts of the lung. Okay, so the organ itself, it can metastasize to, so a different lobe. So it can, in this particular case, it can metastasize to the, within the same lobe, like a satellite nodule. That would not necessarily be called a metastasis. It would be called a satellite nodule. If it goes into another lobe, for example, from the upper lobe on the left side to the lower lobe on the left side, then that will be classified as a metastasis, because it has to go through a hematological spread to get into the other lobe of the lung. It can, of course, metastasize to the contralateral lung. As you said, liver, adrenal, brain, and bone. So talking about the brain, the PET scan is actually not very good at looking at small brain metastasis. If you have a brain metastasis which is 1.5 centimeters or 2 centimeters, of course, it will light up with the PET scan. But if you have a 5 millimeter or 3 millimeter brain metastasis, then it won't necessarily light up in the PET scan of the brain. And what you need to order if you suspect the patient have brain metastasis, for example, they have new neurological anomalies, like sensory or motor deficits or other deficits recently, is that you need to order an MRI brain with contrast to see that. And the MRI brain with contrast will usually be able to detect brain metastasis as small as a few millimeter in size. Okay. For lung, you'll see on the PET CT as well as a CT scan metastasis. For the bone, yes, you'll see a little bit on the CT scan, but the PET will give you the activity that you may need to give it to highlight it as a very suspicious bone lesion. And if we see a bone lesion, lesions can be biopsied if they are accessible to confirm it's a stage 4 disease. Okay. Liver lesions are usually also biopsiable by ultrasound guided FNA or CT guided FNA. Okay, to confirm that it is a metastasis. And if you suspect there's a concomitant liver lesion or liver tumor, then you can check alpha fetoprotein and do, like triple contrast abdominal CTs and things like that to delineate whether it's a metastasis or a primary HCC together with lung cancer the patient has. For the adrenals, it's a tumor that does metastasize to the adrenals. So those areas will be highlighted in the report as well by the radiologist. And interestingly, talking about where these areas the lung cancer may metastasize to, when you order a simple CT thorax with contrast that we were talking about earlier on, for lung cancer or suspected lung cancer, the radiologist will automatically, in fact, do a scan of the lower neck all the way down to include the adrenals. So when you order CT thorax with contrast, they will do that automatically. And that means a CT thorax with contrast to investigate a lung mass, they will be able to see the lower cervical lymph nodes, the SCF lymph nodes, all the ribs, and also the thoracic and the upper, up to the upper lumbar spines. And they'll be able to see the liver, and they'll be able to see the adrenals as well. And the very reason why they do this extensive scan for a suspected lung cancer is because lung cancer metastasizes to those organs. So to pick up potentially more metastasis through a CT scan. For a PET scan, of course, it's the whole body, so that doesn't really apply. As I said, you look for metastasis all over the body. Okay, so if you have a lesion which is bright in the adrenal area, some depending on where it is in the adrenal, it may be amenable for CT-guided FNA of the adrenal lesion to get a biopsy to confirm it. And if it's at the left adrenal, you can actually request a EUS biopsy. So you're thinking like, EUS biopsy, that's strange. Doesn't that go down the esophagus usually to, biopsy lymph nodes or biopsy esophageal lesions? Well, yes, but EUS, in fact, the left adrenal gland sits behind the lower parts of the stomach. And in fact, a EUS can go down the esophagus into the stomach, and with ultrasound can sometimes pick up left adrenal lesions, and they can stick a needle through the stomach into the left adrenal lesion to get cytology or histology to confirm or refute the fact that it is an adrenal metastasis. So that's another way that we can sometimes get tissue. So going back to lymph nodes, of course, if you have suspected lymph nodes, one of your classmates quite correctly said that we should be doing a EBUS for them to biopsy those lymph nodes. So what are suspected lymph nodes for metastasis? There are two main criteria, of course. One is just using the size as a criteria, and the other one is using the SUV, increase in SUV as a criteria for potentially malignant lymph nodes. So for size, you're talking about 1 cm or larger in the non-longitudinal axes of lymph node. Lymph nodes are usually oval in shape, and the shorter axes of the lymph node, if it's 1 cm or larger, then it may suggest that it is diseased with metastasis. And of course, if you have a bright spot in the mediastinum that shows up a lymph node, then that lymph node, whether it's big or small, may be under scrutiny as a potential metastasis in the mediastinum. And we do need to figure this out because we tend not to operate on patients with N2 lymph nodes. And I'll explain a better reason why we don't tend to operate on those patients. So how do we actually go about staging the mediastinal lymph nodes? So first of all, you can use EBUS, which is a larger bore bronchoscope with an ultrasound at the end that you give some sedation to the patient, and it goes into the patient's mouth. You put a mouth guard around the mouth so it don't break your EBUS, and you put it down and through the vocal cords into trachea. And once into the trachea, which is of course this structure here, this black structure here in the middle, you can use the ultrasound to look around the area of the trachea and the carina here in order to identify the lymph nodes that you suspect may harbor metastasis. And with the needle, you can deploy it to biopsy that. Hey. You're still in the axle? Oh, sorry. Okay. That's sorry. Yeah, do let me know. Okay. So, so this is the PET scan. Okay. So this is the bright spot, and so this dark area is trachea. So the EBUS go down this area. With the ultrasound, we would look around this area and around this area and here to look for the lymph node that has been highlighted potentially by the PET scan as being active, and or highlight or look for a lymph node that you see is larger than 1 centimeter on the short axis. Okay. and you deploy a needle under real-time ultrasound guidance into that lymph node, and you jiggle and you aspirate, and then you send it for cytology, and that will give you potentially the answer to whether it's malignant or not. So if it's malignant, the lymph node we're talking about, then we tend to send it to oncology to receive some neoadjuvant therapy. And then potentially they may give it back to us after neoadjuvant therapy, chemotherapy, for surgery later on. And the reason why we don't do N2 lymph nodes here is because the treatment, as you know, for a small tumor like this at early stage is a lobectomy. And during a lobectomy, we take out the lobe and we would dissect out the hilar lymph nodes that are here during the lobectomy. And we'd also sample some N2 lymph nodes, say around this area, okay? But because we go in the side of the chest here, we can't actually excise every single N2 lymph node in the mediastinum. So the fact that at least one mediastinal lymph node is positive means that other mediastinal lymph nodes are probably positive as well. And the fact that we can't clear all the mediastinal lymph nodes means that we're not resecting all the disease when we're doing surgery. So that's the kind of a reasoning that you can take away of why we tend not to do N2 positive lung cancers and give it to oncology to give chemotherapy to clear the N2 lymph nodes, and then do a lobectomy afterwards. So that's kind of a simple explanation in a nutshell. So for N3 lymph nodes, of course, we don't do as well because that's even more advanced stage than N2, okay? So EBUS, the complication rate is very low, and it's even there are reports that even if you mistakenly stick the needle into the aorta, which is this bit here, and if you realize it and take out the needle very quickly, usually it doesn't cause any major bleeding because the needle is quite thin and so on, and the mediastinal structure is quite dense, so you tend not to get a big hematoma and so on. There has been brief reports of having EBUS that introduce infection into the mediastinum, but that's very, very, very rare, indeed. The alternative in assessing the mediastinal lymph nodes, in fact, would be to do a mediastinoscopy, which is a general anesthetic procedure, which is different from the EBUS, and you have to make a wound in the neck, about 2 centimeters in length over here, where you go down this pretracheal plane. So you go down, you put a scope down here behind the sternum, in this area where I've put the cursor, just in front of the trachea where the lymph nodes are. And you push the scope in this plane, just where the tip of the cursor is, into this plane. And you biopsy the lymph nodes, holding the scope, and you look through the scope through a television, like a thoracoscopic procedure, but just going through some structures here. Now, of course, this procedure, you have a scar, you have more pain because of the scar and the dissection, and you have to have a general anesthetic. And you can understand by pushing a scope in this very narrow area, you're next to the SVC, which is here on this side, and next to the arch of the aorta on the other side. And of course, a wrong move would mean bleeding, and bleeding often in these areas would be uncontrollable using a scope, which means you may need to convert to a sternotomy for hemostasis. So those of us who've done mediastinoscopies day in and day out would have encountered one case in their lifetime as a surgeon where you need to open the sternotomy to stop the bleeding and repair the aorta or the SVC. So it's not a nice thing to do. If everything goes well, the patient can go home at night or can go home the next morning. So, yeah. Someone got a question? No. Okay. So, the procedure is usually, if it goes well, it's fairly atraumatic and it's just left with a small wound. They can go home very soon, within around 24 hours, but there are associated complications of bleeding. And there's also associated complications of introducing infection because you have an incision here and you're pushing, your scope into the mediastinum, and infection of the mediastinum can potentially result in very severe infection called mediastinitis, which has a very high mortality rate. Again, it's very rare, but if it happens, it's a bit of a disaster. And the third and the fourth things that can happen is that you can create a pneumothorax by pushing the scope too laterally and introducing air into the pleural cavity, as well as damaging nerves such as recurrent laryngeal nerves around the arch of the aorta. So it's a procedure which in general is very safe if you know how to do it, but it can have complications, unfortunately, at times as well. So those are the complications that you may be expected to know, maybe in a multiple choice of a mediastinoscopy that I just mentioned. Okay. So EUS, yeah, it does. Okay, so very good. So EUS does have a role in mediastinal staging, and is to look at lymph nodes that are more in the posterior aspect of the mediastinum. So this is the mediastinum, as you can see here. And this is the, if I just enlarge this area, and you'll see here, this is the trachea, and this here is the esophagus. This is, of course, the descending aorta here. So the esophagus is here. So, for example, if you have a lymph node over this side between the aortic arch and, at this area, or more posterior aspect here, and so on, you can understand what I'm saying. It may be easier or have better access if you go down with a EUS that goes down the esophagus, which is this hole here, in a more posterior position, in order to sample the lymph nodes. Also, lymph nodes that are in the lower part of the thorax may be better sampled by EUS. So as you know, the trachea comes down to the level of the angle of Louis, where it bifurcates. Yeah. So in fact, that's as far as you can go, this bit, in terms of the mediastinum, by EBUS, because you're going down the trachea and you reach the carina and you go left and right. So you can sample a little bit of the hilar lymph nodes with the EBUS. But if you have lymph nodes that are further down in the lower half of the mediastinum, then the EBUS just cannot go any further because the trachea ends at the angle of Louis. So you have to go down the esophagus, which of course goes right down to the bottom, down to this far down as the diaphragm and beyond. And if the lymph nodes are around that area, then you have a better chance of hitting it with a EUS. So I hope that kind of help explains a little bit. So sometimes when we give sedation to the patient in endoscopy center and they have lymph nodes at the upper part of the mediastinum and lower part, we may do a double procedure. We may do a EBUS by us, and then the general surgeons come in and do a EUS to do a lower mediastinal lymph node biopsy, plus or minus adrenal, left adrenal, if there's a lesion there on EUS. Okay, great question. Okay, so how would you choose, first of all, between a EBUS and a mediastinoscopy? So in general, certainly in the developed world and the Western society, we would choose EBUS as a first line because it's much less traumatic. It doesn't involve a general anesthetic. It doesn't give you a scar. It's much less chance of infection, bleeding, etc. Now, if you biopsy a EBUS, if it's positive, the lymph nodes, then that's fine. That's N2 disease, and you send it to oncology. If it's negative and that lymph node is highly suspicious based on your PET-CT and your CT scan, and you don't believe that result, and you want more tissue, then you may subject the patient to mediastinoscopy after the EBUS is negative. Okay, so that's kind of how the sequence of how it really should be done. The mediastinoscopy, the slight advantage of doing all of this surgery is that when you go down with a with a scope is that through the scope, you can actually take big chunks of the lymph node. And sometimes you can actually even dissect out the whole lymph node and take the whole lymph node out in some circumstances. And that gives you a lot more material and gives you a slightly less false negative rate. So again, an excellent question is if PET is negative and your CT is negative, so you have small lymph nodes throughout your mediastinum and nothing lights up, like in this PET CT, do you still need to do the EBUS? Okay. So I'm just trying to give you a simple answer. If you go to America and the society guidelines there would suggest that almost everybody should have a EBUS because it's a fairly harmless procedure. And on the ultrasound, on the EBUS, you may see lymph nodes that are a little bit abnormal, and you may just do a few passes of needle, and you may pick up around 2 or 3% of patients who don't have mediastinal lymph nodes on imaging, but is positive on EBUS. So you may pick up 2 or 3% of patients that should not have surgery by doing this. Here in Prince of Wales Hospital, because resources are very limited, we can't put everyone that has lung cancer, through EBUS. I mean, if you look at our waiting list for lung cancer, it's like 3 months. So if you put everyone through EBUS, then the queue will be even longer. So we only do EBUS for patients who have enlarged lymph nodes on CT, which means it's suspicious, or they are PET positive with the FDG uptake. And for those who don't have any suspicious features, we don't do EBUS staging in Prince of Wales Hospital. Now, this management is actually quite acceptable. If you go around a lot of places in Japan or Asia, a lot of people do that because you seem to be wasting a lot of resources by doing EBUS on everybody to pick up the 2% of patients that you would pick up. But of course, in somewhere like US, that's what they would do because they've got, insurance and got lots of money. So I hope that kind of explains a little bit. Might I clarify if we only do EBUS to have enlarged lymph nodes? So yes, in Prince of Wales Hospital, in Hong Kong in general, in other centers in Hong Kong, and in most places in Asia, Taiwan, and so on, this is what we'll be doing. Yes, so we don't, because it takes about 45 minutes to an hour to do a EBUS properly, and if you do that for everybody, we just don't have the time slots in the endoscopy center to do that here. Okay, great questions. Thank you for asking, and shows that you guys are thinking. Brilliant. So assuming, I think we kind of got over those things. So assuming that basically this person is free of any metastasis to the lymph nodes or distally, assuming the patients also had MRI brain, there's no metastasis to the brain. This is a small early stage adenocarcinoma, a primary adenocarcinoma based on staining that we got from the FNA, CT guide FNA. What would be the treatment? Gold standard treatment for this patient. What surgery will I perform? Lobectomy, yep, excellent, very good. Okay, so the gold standard for lung cancer remains to a lobectomy, okay? And for early stage lung cancer remains to be lobectomy. So that means taking out a lobe. As you know, we've got 5 lobes in our body, and each lobe is sized differently. So not all lobes are equal in size, which brings me to the question as what investigation do we need to do before we can say a patient can tolerate a lobectomy or lung surgery?
Pulmonary function
Lung function
test.
tests.
Yep, absolutely. Lung function test. So, of course, they need to have, blood results to be relatively reasonable. They need to be in reasonably good health. They don't have, like ongoing critical angina and, or something like that, or, or moribund or other things like that. But essentially from a thoracic surgeon point of view, when the patient we're considering for lung surgery or lobectomy, we need to see their lung function. In your handbook, of course, we do two forms of lung function. One is a simple spirometry, which looks at your FEV1 essentially, and we do a DLCO, okay, to look for gas diffusion. Okay, so going back to simple spirometry, the main number that we look at is FEV1, which is, as you know, forced expiratory volume in 1 second, and that tells you a lot about, the reason why we look at that is there's a lot of papers that show that FEV1 predicts outcome for the patient. Papers as far back in the 1980s that show that is a very good predictor of outcomes in terms of post-surgery complication, their need for ICU after surgery, or mortality after lung resection. And that's because, as you know, people with COAD or bad airway disease, they will have a often reduced FEV1. Of course, they have a reduced percentage of FEV1 over FVC as well, suggesting an airway obstruction or airway narrowing in those kind of diseases, COAD. But also FEV1 not only just look at whether the patient has COAD or airway disease, but it actually looks at the general respiratory condition of the patient. Because if you think about what FEV1 is measuring, is looking at how forceful a patient, how much air a patient can force out in 1 second. And that depends on how narrow the airway is, but how strong your respiratory muscles are as well. And how, if the patient is very cachectic or has very poor strength in their respiratory muscles or accessory muscles, then the FEV1 will be lower as well, okay? Also, it looks at your lung compliance and your chest wall compliance as well. You remember compliance is the change in pressure versus the amount of volume that you're shifting. So if you have a very stiff lung, it means that even if you're squeezing the lung, then you're not going to get much air out of your lungs as a contributing factor to FEV1. So if you have stiff lungs, stiff chest wall, poor accessory muscle or respiratory muscle strength, and of course COAD or airway disease, then your FEV1 will suffer. All of these things. And you can imagine how that will contribute to risk prediction after lung surgery. So, as you know in your handbook, a FEV1 of around 60% predicted would be sufficient for you to have a lobectomy in general. That would be the number. And if you have 80% predicted FEV1, that will be enough for a pneumonectomy. Pneumonectomy meaning whole side of the lung being removed. Now, why do I say percent rather than absolute volume? Because the volume of FEV1 differs by your age, your gender, and your height. So my FEV1, if I blow 1.5 liters FEV1, it will be very different from a old lady who is 5 foot tall, making the same value of 1.5 liters FEV1. FEV1 of 1.5 liters for the old lady who's 5 foot tall would be like maybe 100% predicted for her size, gender, and also age. But it may only be 50% for me in terms of my gender, age, and height. Okay, so we normally look at the percentage as a gauge. And DLCO, of course, looks for the gas exchange capability of the lung. So not so much the volume exchange, but the gas exchange capability of CO diffusion, carbon monoxide diffusion. So if you have some lung fibrosis, which mean that there is affecting the gas diffusion surface between the alveolar and the capillary membrane, the capillary network that encompasses the alveolar, then that will affect, of course, diffusion of gas, and that will affect the LCO. So you can theoretically, with lung fibrosis, pulmonary edema, other kind of lung diseases that are destructive, in fact, have a very poor DLCO, but a reasonable FEV1, because the material that you have in the lung is not doing its job of gas diffusion because it's all damaged. So DLCO is also helps predict outcome after surgery. Easy to remember, you need 60% predicted DLCO for lobectomy and around 80% DLCO for a pneumonectomy. That's as a ballpark figure. If you want to be more precise, you will see in your handbook that it explains how you can calculate how much percent you are left with after you do the resection. And how you do that, you basically have 19 segments in your lung, okay? 9 segments in your left side and 10 on your right side, okay? Slightly less segments on the left side because of the heart on the left side. And each lobe has different number of segments, okay? So right upper lobe has 3, right middle lobe has 2, etc. So the smallest lobe is the right middle lobe, okay? And you divide what you have. So for example, you have 60% FEV1, and you divide that by 19 to get the rough percentage per segment. And you subtract, for example, if you're doing a right middle lobe, 2 segments. So you'll be removing, about for a 60% pre-op, you'll be removing like 12% or so of the FEV1 from the 60%. Essentially, you need, for a good outcome, it's best that you're left with 40% of your remaining FEV1 or DLCO to have a low risk of complications. Okay, so that's kind of how it works. And for example, if you're taking out the left upper lobe, that's 5 segments. So that's a big lobe. And 5 segments out of 19. So you're taking out more than a quarter of your lung function. So you need to remove a quarter of your DLCO and FEV1 percentage. And if you're still left with 40%, then you're good to go in general. Does that kind of make sense? Yeah. So you look at lung function, and if it's good, then you can do a lobectomy. Lobectomy we can do now these days, over 90% we do by VATS, which is minimal invasive surgery, with a few small keyholes that a few, it can be 3, 2, or 1 keyhole, depending on the expertise and difficulty of the case of the surgeon. But essentially, how many holes usually associated with fairly rapid recovery. If it's a smooth procedure, blood loss is like 20, 30 mils, and we don't really need to give blood transfusion. And after the procedure, we are left with the drain inside the patient, and we remove the lobe, and we have to divide artery, vein, and bronchus of the lobe, and do mediastinal lymph node dissection and hilar lymph node dissection for the area, just much like other cancer surgeries. You may remember that in my tutorial during a rotation, I showed you a X-ray with a chest drain, with a last side hole and a chest drain in situ. So that will be like an X-ray that you'll see in recovery after lobectomy. Complications associated with lobectomy, you may or may not be expected to know a little bit about. Of course, the general complications of any surgery, the complications associated with general anesthetic, and then more specific complications. Now, more specific complications in a lobectomy is major bleeding. You may say bleeding is any kind of surgery. You can bleed, yes, but we are dealing with big vessels when we are dividing the lobar pulmonary artery and the lobar pulmonary vein that can potentially bleed to death in minutes if it's not controlled. So bleeding is a potential complication. Infection is also a interesting complication. You say, well, any surgery can cause infection, right, of the wound and so on. Yeah, wound infection. But in a surgery within the chest, we can actually get pleural space infection. And pleural space infection can end up in empyema. And that is another more procedure-specific complication. Other complications that are more procedure-specific, as I said, with lymph node dissection in the mediastinum, we may injure lymphatic vessels. In particular, we may damage the thoracic duct, and the patient may have chylothorax as a complication. And similarly, when Team 2 surgery do esophageal resection for esophageal cancer and lymph node dissection, they may also end up with chylothorax as well, for the same reason that they are doing a lot of dissection within the mediastinum and the chest. And that's where all the bigger thoracic ductal branches come together. The fourth, perhaps specific complication associated with lung resection would be air leak. As you know, the lung is one of the only lung air containing organs in the body, if you like. And when you do a lobectomy, often you do need to go through some lung parenchyma. We use surgical staplers to staple across that, but some of the staple lines may also have air leak. And that's also the reason why we leave a chest drain in situ after the operation, in case not just to drain the blood-stained fluid after the surgery, but to have drainage of air in case there's air leak out in the chest drain. So that's, I think, really everything you need to know for short answers and to get by in short answers, and also multiple choice for lung mass workup, lung surgery, lung cancer in the exam. Any questions? Happy? Okay. Right. I'll move on rapidly onto another potential topic. All right, so let me do this quickly. So another common topic, apart from lung masses or lung cancer, whatever, is this. So I hope you can see my X-ray. So this is a patient who had a X-ray 1.5, 2 years ago on the right-hand side, and 1.5, 2 years later, the same X-ray on the left-hand side of your screen. Anyone able to tell me what the problem area is here?
Is it a widened mediastinum?
There is. Very good on the right side of the patient. I'm just going to answer the question first. Sorry, from a Hiu Ying Tong. Okay, sorry. May I clarify again if can proceed? Lobectomy, yes, is correct. Yes, absolutely. Good. Okay, so going back to this. So in fact, there's a bulge here that has grown in size. So retrospectively, you could say that, yeah, you can probably see something here, but this is just hilar, right, of the lung. You could be forgiven very easily that you missed this, but this is a bit unusual. Certainly, this will warrant further investigation in terms of imaging. Yeah, it could be some funny vascular aneurysm. It could be some funny growth of something. It could be a cyst. It could be something, right, in a collection here. But this is certainly abnormal. Okay. And in fact, the topic I'm going to go into next is anterior mediastinal mass. Okay. So with anterior mediastinal mass, when you do an X-ray like this with overlapping shadow in the mediastinum, there are two ways. There's one way to try to differentiate whether this lesion is from the lung or from the mediastinum. Okay. So I'm just I haven't stopped talking. I'm just trying to draw on a piece of paper to show you. So when you have a lung lesion, okay, and then you have a mediastinal lesion. I'm just drawing on a piece of paper. Don't worry, you're not missing anything right now. Okay, so what I'm talking about is really this. So you can have, when you do a chest X-ray, so this is the mediastinum, okay? Sorry, these two are the lungs on either side of the cross section. So you can actually have a lung lesion, this small lesion here, that overlaps with the mediastinal shadow when you do a PA film, okay? So what you might see in the chest X-ray here. But you can also, in fact, have a lesion which is not from the lung, but from the mediastinum here, growing out of the mediastinum, okay? And like a lesion that bulges out from the mediastinum with a intact pleura. So this mediastinal pleura here is intact, okay? So one way to potentially differentiate these two is this. So for the one at the top, the one at the top here, what you have is that on the X-ray, you'll have the mediastinal edge going down, okay? And then you'll have an overlying shadow like this of the lung, yeah, a ball. But this angle here is very sharp. This angle here is very sharp. So this angle. Where the arrow is, okay, is very sharp. If you have a mass that pushes out from the mediastinum and includes the mediastinal pleura, then usually the angle is much smoother. Can you see? So the angle of the mediastinal edge here on the X-ray that I'm showing you here would be quite smooth. So this is actually quite a smooth edge that you can see. I'm using my cursor to show you here. And oh, stop the share screen. Okay, sorry. Yeah, I can do that. Stop share. Okay. So, oh yeah, because it was very small, right? I got it. So this is, as I say, is the overlapping shadow from the lung, the tumor from the lung here, overlapping the mediastinum at the cross section. And that will give you a very sharp angle here when you do a PA film, right? This long edge that goes down is the mediastinal edge on the right side. And this lesion here is the lung lesion. And this overlaps, yeah, because it's superimposed on the mediastinal edge. So this will give you a very sharp angle. If the lesion, on the other hand, is more coming out from the mediastinum this way, the pleura of the mediastinum here will be intact. Yes. And what will happen is that the angle here would be quite smooth. Yeah. So if I go back to sharing, yeah, a little bit. Yeah, you can say that. Yeah. But, yeah. So you can kind of understand, with the overlapping shadow, you get a sharper angle in those areas. Exactly. So if you go back to sharing, this one. Yeah. So this is actually quite a smooth, edge. You can almost kind of see it bulging out of the mediastinum over here, okay, rather than a very sharp angle. And you can certainly see a bit more here that is more smooth, okay. So this would be, I mean, you can't say for sure because it's not a CT scan, but, you know, if you have to bet on it, it'll be more a lesion from the mediastinum. And the fact that it's grown over 1.5 to 2 years means that it's not like a lung carcinoma, because the patient usually will be dead if the patient has a lesion like this 2 years ago, and it wouldn't have grown just a little bit. Usually it would be much more aggressive in general, although not always. Okay. So, but anyway, you see this, you can't be sure. So when you see a bulge like that, your next thing you need to do is essentially you need to get a CT scan, right? So again, get a CT scan with IV contrast if you can. And then you will, hope you can see this. There we are. So this part here is the anterior mediastinum, okay? This part of the mediastinum, okay? This part with all the important structures is the middle part of the mediastinum, okay? And then behind that is the posterior mediastinum, okay? So this is the anterior mediastinum, okay? Just behind the sternum, but in front of these important structures such as the aorta and SVC. This is a mass in the anterior mediastinum, okay? And when you see a mass in the anterior mediastinum, there are those several differential diagnoses that you need to go through in your mind. And they are, what are they? So I'll give you the easy one, thymoma. What else? Yep, very good. Thymoma, lymphoma, yep, thyroid germ cell tumor. Excellent. Okay. So, these are the things that potentially you can ask in multiple choice because we expect you to know, as a general knowledge. It's easy to ask, in multiple choice because it's, you know it or you don't, and it's a mark or it's not a mark, or even in short answers. And so these are the four. And of course, beyond this, if you're asking a Viva, for example, then in a pass fail, or better still in a honors Viva, then you can go on to say more. In the anterior mediastinum, behind the thyroid, there's parathyroid glands, so you can get a parathyroid tumor. And in the anterior mediastinum, there are also lots of fat tissue, mediastinal fat. So any of those tissue can give you a cancer, a tumor like liposarcoma, lipoblastoma. Yeah. Blood vessels in the anterior mediastinum can give you angiosarcomas and things like that. So you can go on forever what types of tumors can occur in the anterior mediastinum. But of course, you need to say these primary ones first to get your pass. Yeah? Okay. So with these in mind, in your clinic and you see the CT scan, what would be your blood test that you need to do? So again, this is essential information for your multiple choice and short answers. Blood tests you need to do. Germ cell tumor, what will be elevated? So HCG and alpha fetoprotein, excellent. Yep. LDH for lymphoma, yep. And thyroid function tests for a thyroid, yes. Very good. Okay. So HCG and also alpha fetoprotein as well. We usually would check both of them. As a matter of routine, you need to write these down first, of course, what you've written down, Tin Long, okay? But you may, if you're asked to add more in a Viva situation, you may say you want to check CEA as well. Also, if the patient has signs and symptoms of myasthenia gravis, you also want to check antibodies against the acetylcholine receptor as well. Okay. But LDH, HCG, alpha fetoprotein, thyroid function test would be our basic. And also you can also say like calcium levels and so on, but that will be the second tier blood test. Yeah. Right. So Reason why we do that is the HCG and alpha fetoprotein. Normally, as you know, the normal value would be single digit, say 8, 9, 10 as the upper limit. And unless you're pregnant, of course. Then if you have this lesion, for example, in a person who's not pregnant, and the value is in the thousands or tens of thousands, then it is basically diagnostic of a germ cell tumor. You actually really don't even need a biopsy to refer the patient to oncology. And why refer to oncology? Because actually germ cell tumors, we do need the oncology input to usually give some chemotherapy first before we consider surgery. So they usually undergo chemotherapy as a definitive treatment or chemotherapy as a neoadjuvant treatment if it's a germ cell tumor. Okay. For LDH, if all the others are negative and then you have a relatively elevated LDH and your CT scan report says lymphoma is quite likely, then you need histology to confirm that. Okay. And histology, you need to order CT guided true cut biopsy. Okay. So I stress that you need to order true cut biopsy rather than FNA, because a true cut biopsy will give you more tissue to differentiate which type of lymphoma it is. Whether it's Hodgkin's, non-Hodgkin's lymphoma is important to know because the drugs that are used to treat these lymphomas are quite different. So with an elevated LDH and all the rest are not elevated, the lesion looks like lymphoma in the CT report. You order CT guided true cut biopsy. It comes back perhaps as a lymphoma of sorts, Hodgkin's or non-Hodgkin's, and you refer the patient to oncology. And the reason why is that for lymphomas, of course, as you know, with chemotherapy alone, they have like 95% 5-year cure rate or survival without any other treatment, without surgery and so on. So chemo is by far the most effective for lymphoma. And quite often lymphoma, the lesion is much more infiltrative around the major structures. So it's very difficult to resect with surgery completely anyway. So chemo will be the treatment. For potential thyroid, you may have a clue because it may be an extension of a thyroid or goiter or a thyroid tumor from the thyroid in the neck. And that would give you a clue that it's from a thyroid origin. Sometimes, occasionally, you do get ectopic thyroid. I've seen like 2 in my truly large ectopic thyroid glands in my career. Of course, I'm not a thyroid surgeon. The thyroid surgeon will see more, but a thyroid ectopic tumor or enlarged goiter lesion that looks like this deep in the thorax is quite rare, but it can happen. And that you may get an indication of that from TFT or you may not. Okay. And if everything is negative, then essentially you may suspect that this is a thymoma. Of course, you need to, as I say, check whether the patient has MG symptoms. If the patient has MG symptoms, it's most likely related to a thymoma. Although MG does not need to have a thymoma to have MG, and vice versa, you don't need MG to have the thymoma. So they can be related, but not exclusively related to each other. If you have MG as well, you need to check the antibodies, and that will cause some perioperative management changes as how you would anesthetize the patient and how you would require ICU after surgery for the particular patient. So that's important. Essentially, if you suspect this is a thymoma on the CT scan and the blood tests show that it's not otherwise, and you feel that it is resectable, you would offer surgery as primary treatment for a thymoma. Okay. The standard treatments for thymoma surgery would be a total thymectomy. So you would excise the thymoma and or the thymus as well. So it's called a total thymectomy. And that is so that you remove other thymic tissue that may have in the future may grow into a thymoma at 10 or 5 or 10 years later. Or sometimes you get a satellite nodule from this thymoma in another thymic tissue, another part of the thymus. So you do a total thymectomy. You can do that via a sternotomy, which is through the sternum, or if this lesion is small, say less than 5 centimeters, you can do it through VATS, okay, video assisted thoracic surgery from the side of the chest. Okay. Potentially, during the surgery for total thymectomy, apart from potential injury to the vessels that you see are very close to the lesion of the anterior mediastinum that's around this area, the anterior mediastinum, like the aorta or the SVC or the pulmonary artery here, there is a pair of nerves that go down the mediastinum to the diaphragm. And of course, that's the phrenic nerve. The phrenic nerve, in fact, travels just anterior to the hilar. So this is the right hilar where it gives off these blood vessels to the lung. So the phrenic nerve is around this area here, okay? Going like from the neck, traveling down this way towards the diaphragm. And if you're not careful, you can damage the phrenic nerve during the surgery. So you need to be very careful. And bigger thymomas may actually involve the phrenic nerve, in which case you may need to sacrifice the phrenic nerve to get a total resection of the thymoma. Sacrificing one phrenic nerve is okay, but if the thymoma is so big that it involves 2 phrenic nerves, then you should not sacrifice both phrenic nerves because that will render the patient difficult to wean off the ventilator, if ever at all being able to wean off a ventilator. Okay, so we cannot have 2 missing phrenic nerves. Okay, one is okay. What else do I need to say? For short answers, I guess that will be the only time that it can come up. When would you do a biopsy for a thymoma to confirm it's a thymoma? So if you think that this thymoma is not resectable or cannot be completely resected, you should consider doing a biopsy so that it confirms the diagnosis, and then the oncologist can give some neoadjuvant chemotherapy to shrink the thymic tumor so that you can then go in afterwards to do a R0 resection. R0 meaning that you don't leave any tumor behind, yeah, total resection. So this is one circumstance. The other circumstance where you may consider biopsying a suspected thymoma is if you suspect it's a thymic carcinoma. So you think like, whoa, what's this? What's a thymic carcinoma? You've been talking about thymoma all the way along. So thymoma, there's a spectrum of aggressiveness in terms of the cellularity of the thymoma. And there are different categories, and up to a certain point, you would still call it a thymoma. But beyond the aggressiveness of the cells that they see within the tumor, you would label it as a thymic carcinoma. And when will you find a thymic carcinoma? In bigger lesions of the anterior mediastinum. So for example, if this lesion here is around 8 or 9 centimeters, which isn't really that big. I mean, they can grow to 8 or 9 centimeters quite easily without giving too much symptoms because they just grow laterally and just take up a bit of lung volume, but it doesn't actually cause much symptoms for the patient, particularly for the young patient. And if you have like an 8 or 9 centimeter tumor in the anterior mediastinum, like this size here, you would start to suspect this may be a thymic carcinoma, because the larger the tumor that is of a thymoma, the more likely it's to harbor these aggressive cells that would classify as a thymic carcinoma. And you would, for a thymic carcinoma, you would tend to biopsy it first, and there'll be a discussion in MDT whether to give some neoadjuvant chemotherapy before you do the total thymectomy surgery. So there are really two scenarios. One is that if you think that you cannot resect it totally, then you may biopsy it to confirm its diagnosis so that the oncology can give some chemotherapy, neoadjuvant chemotherapy. Or two is that a very big tumor, like 8 cm or more, where it's much more likely to be of a thymic carcinoma cellularity, you biopsy it with CT guidance and then have a discussion MDT to whether to give some neoadjuvant chemotherapy first before you're going to do surgery to have a better outcome. I think that's all I need to say about anterior mediastinal masses, which isn't much. And that's the second most common topic, or the second biggest topic in thoracic surgery you need to know. So that's pretty good, isn't it? I've gone over time. I think the third topic that you need to know a little bit about that can come out multiple choice and perhaps, like on the X-ray or something would be pneumothorax. So, of course, there's a part in your handbook that talks about primary spontaneous pneumothorax, the surgery that we do, and also the indications for patients requiring surgery like recurrence or persistent air leak or incomplete re-expansion of the lung, or hemopneumothorax or bilateral pneumothorax, or a patient who's got a specific occupation, like their airplane pilots or something like that. So those are all in your handbook. So those are easy to make some multiple choice questions out of, because they're like definitive answers you can give. So how generally you manage that kind of pneumothorax, how you manage secondary or pneumothorax that occurs due to a secondary cause like COAD and stuff. So that's a lot of it's kind of more medical now. So you probably cover some of that in medical as well. And the fourth topic you need to know a little bit is read the bit about trauma in your handbook as well. Okay, so but we won't have time to go through all of that. My understanding is that I have another session, like revision lectures before your final exams, because this lecture or this tutorial is meant for the end of specialty multiple choice exam. So on that pre-exam, final exam revision lecture, I'll go through some of those other topics as well. Okay, so don't worry. So wonder if we simply resect the anterior mediastinal tumor without biopsy? Yes, we do. If you think that it is a thymoma, let's say we think that it is a thymoma, yes, with normal blood tests, yeah. Will there be a problem? Eventually it comes back to be lymphoma or germ cell tumor. So for germ cell tumor, it's very rare to have normal HCG and alpha fetoprotein levels. So a normal for both really excludes it from the normal type of germ cell tumor that should undergo a chemotherapy first. So no, we rarely see that. We may find resected and there'll be a teratoma, mature teratoma. We've seen that before. Like a very heterogeneous mass like this, that may have some calcification, some heterogeneous tissue inside. We don't know what it is. It doesn't look that much like a thymoma, but it's just like a mass there. We can resect the whole thing. And it turns out to be a mature teratoma. So that's fine, because even if we biopsy it and we know it's a mature teratomas don't need chemotherapy beforehand. We will resect it. And mature teratomas don't have the very elevated alpha fetoprotein and HCG. Yeah. So you don't have to worry about that. If it comes back to be a lymphoma, so in fact, we rarely make the wrong diagnosis because lymphoma usually on CT is much more infiltrative. It's not like a bulging mass like this. And you have a slightly elevated LDH. And those things, if you're unsure, may already prompt you to do a biopsy. And that would give you, the diagnosis, because you're thinking, okay, it could be a lymphoma. It could also be a thymoma. But there's like a 30-40% chance it's a lymphoma because it's elevated LDH, and it looks like a lymphoma because of its spread. It's like how it's sort of infiltrative. So let's get a biopsy first. Yeah. And if it turns out to be a thymoma, it's no harm that we've biopsied the thymoma. We just then do the surgery. But it will help us catch the lymphoma. So management wise, we rarely get caught out in this particular case. There is a very strange type of lymphoma that is very slow growing, that looks like a mass, that looks like this, that I've seen once or twice. I can't remember the name to save my life, but if you mistakenly cut that out, actually it's not a crime at all, because that type of strange lymphoma surgery is actually an acceptable first-line treatment because it's very slow growing, it's very mass-like, it's not very infiltrative. So it's not a big problem. Okay. Sorry to ask, where local invasion on CT points more? Yes, correct. So there are certain things that, since you asked, and you're obviously very keen to know more about this. I've gone over time, but I've got time. It's no problem. Thymic carcinomas, yes, they will tend to be more invasive. The edges on the CT will be more craggy edged, much more rough, and even sort of infiltrative in nature. This is very smooth edge, as you can see here. You may see my cursor. I'm using it to point here, very smooth edge here. So a carcinoma will be more craggy edged. It may even invade into the local lung tissue, and so on. And also, thymoma is the only tumor in the body that I know when it's calcified or has specks of calcium, it means it's more malignant. So normally in a tumor, anywhere else in the body, having specks of calcium means tumor has been there for a long time. It's a more chronic process that has allowed calcium to be deposited into the tumor. But thymoma is the only tumor I know that when you see bits of calcium inside, it suggests that it's more likely to be a thymic carcinoma. So this is a very interesting fact. Okay, if you can find another tumor in the body that behaves in the same way when the calcification suggests it's more malignant, then let me know. But thymoma, going into a thymic carcinoma, is the only tumor I know that calcifications mean bad, means carcinoma. Okay, whoa, lots of questions. Let me go go next one. How sensitive is LDH for lymphoma, this type of mass? Again, a very, very good question. So I think the upper limit of LDH value, for example, in PWH is like 270, 280, around that kind of value. There's a range, of course, the plasma LDH we're talking about. In a lymphoma, you may see it going up to 350, 400, 420, something like that. You're not going to get 5,000 or 2,000 or something like that. So you're going to get an elevation of about 1.5 times or 2 times the normal range. And that is already something that clicks when you see a CT scan with a slightly more infiltrative pattern of a mass in the anterior mediastinum. And that would be enough to prompt you, together with a CT scan report that says lymphoma is a possibility, to do a biopsy. So there's no harm if it comes back to be a thymoma, if you biopsy it. It's just that we don't biopsy every thymoma because that's just a kind of waste of resources. So if you feel that it could be a lymphoma based on LDH, based on its CT report, you can biopsy it. Comes back as a thymoma, it's no problem. You haven't really done any harm. Just refer the patient to the CTS surgeon to have surgery, total thymectomy. Yeah. About thoracic trauma, what is the indication of insertion, chest drain? Oh my God. So this is like a really long answer. And in some ways, we're not going to be asking a question like in this way, I guess. In the trauma, if I can answer that in like a few sentences, is that indication for insertion of a chest drain. So what is a chest drain used for? Chest drain is used for to relieve things in the chest that you don't want. Okay. So if you have a significant amount of blood in the chest on a chest x-ray, or significant amount of air in the chest x-ray, or you suspect the patient has a lot of blood and air in the pleura, so you haven't got a chest x-ray yet, but the patient's desaturated and you don't hear any, air entry on one side. Okay. The trachea is deviated, or you have hypotension and you suspect one side there's no breath sounds and it's dull to percuss and you think there's a lot of blood inside, then those circumstances you would put in a chest drain. So chest drain you would insert if you, in general, you have to think about why you're doing something. So you want to drain the air and you want to drain the fluid that's inside, usually blood in the case of trauma. You want to see if there is air or blood if you have a very unstable patient, okay, based on your clinical signs. And you want the chest drain will also have an additional function of monitoring the blood loss or air leak for you as well once it's in. Yeah. So if you like, those are the principles of why you would put in a chest drain. And for emergency room thoracotomy, two things you would do for emergency room thoracotomy. One is that in the literature, when you have a massive drain output from your chest drain of more than like 1 liter or like 1.5 liters, something like that, there's a major bleeding inside, and you may consider a emergency room thoracotomy. That is if you know what to do once you've got in with your incision. So if you don't know what you can do or what you're capable of doing, it's better to send the patient to the OR because you have limited instruments and you don't know what to do. But if you do know what to do and you know how to stitch up things and you know how to do a lung twist and you know how to release the inferior pulmonary ligament to do a lung twist and you know how to clamp the aorta, then of course you can do emergency room thoracotomy for a massive bleeding that you suspect is due to those injuries. So I don't know whether that, but I mean, yeah, it's difficult to answer in a short time. I mean, these two questions I can answer in like an hour or 2-hour lecture. So I'm sorry about that. But essentially those are the things that you'll see in textbooks, the gist of it. Okay. YCA. Yeah, I've seen some strange tumors that look like anterior mediastinal masses that are like small cell tumors or mesenchymal tissue tumors that occasionally may have elevated CA. You can sometimes pick up very strange things like, patient actually has a colorectal cancer that has metastasized to the mediastinum lymph node, and you have a big lymph node in the anterior mediastinum that's like 3 or 4 cm in size. That's actually a colorectal met. So I've seen strange things, and CA is so cheap. So you're sending a tube of blood, and for those reasons I described it. So it's a good question because you should do something, and when in the exam, and the examiner will ask you why you're doing this, you should have an answer at least one answer, explanation for why you're doing it. And I gave you those answers, basically that it could be, I've seen metastasis from elsewhere, from a GI tract, presenting as a anterior mediastinal mass as a metastasis, and you can pick them up sometimes as a cheap test to do. Do you usually do a true cut biopsy for lymphoma for true cut biopsy, for lymphoma. If you suspect lymphoma. It's usually done by excisional biopsy for lymphoma. Not excisional biopsy. A true cut biopsy usually would be sufficient to diagnose, give you sufficient architecture with the core tissue to differentiate the type of lymphoma to start treatment. As you know, I think still is that chemotherapy is the first line treatment for most types of lymphoma. So that is my take. Excisional biopsy, you can do if you still cannot differentiate what it is with the true cut biopsy. But last time we did excisional biopsy for lymphoma to get a diagnosis, I think it's been a while. I can't really remember last time I did one. So preoperative lung function evaluation lobectomy. I heard that the American guidelines adhering to a pre-op. No, I think 60% is enough for a lobectomy, because you can work it out. For a lobectomy, the most number of segments you're going to remove is actually 5 segments. The largest lobe being the left upper lobe, which has 5 segments, or the right lower lobe, which has 5 segments. So those two are the biggest lobes with 5 segments. So you have 19 segments in the body. So 5 segments is basically a quarter of your lung function. So you have 60%, and a quarter of 60% that you remove, you still have, last time I did maths, was 45% lung function left. So with a 60% pre-op, you divide 60 by 19 and you remove 5 of those 19. Yeah, so it will be around 45% you're left with if you had 60% beforehand. But if you do a pneumonectomy, then 60% is not enough, right? Because pneumonectomy, you're halving your lung function. So halving your lung function, 60%, that will leave you with 30%, and 30% is not good. We want 40%, preferably after you removed your lung, your lobectomy, to be safe. I hope that kind of answers your question a little bit. Thank you. What we can do if chest drain fails to re-expand the lung, we can apply suction. We can check that the drain is functional, and we can make sure the drain is in the pleural space. First of all, sometimes X-rays can be deceiving. It can be outside the pleural cavity and outside the ribs, although it's still overlapping shadows. Means that you see a chest drain going like it's in the chest, but it's actually outside the pleural cavity. Make sure it's swinging, make sure it's functional, add suction. And if it's still not re-expanding the lung, you get a CT scan, a plain CT scan, to make sure the drain is in the area where the pneumothorax is. Because sometimes the area where the pneumothorax is actually septated or walled off by the lung. So the drain is not actually in the space. Although the pleural cavity is a unified space, sometimes the drain can be closed off by some lung tissue or the drain may be in a fissure of the lung, and it's not draining the space at the top. So you can get a CT scan, a plain CT scan, to confirm that the drain's actually in the space that you want to drain. Still doesn't expand, you can put in another drain, and then it gets more common. You have to diagnose what the problem is first before you do all those things. But essentially, the first things you need to do are the things I just said. If it doesn't re-expand, difference between true cut biopsy, excision. True cut biopsy. True cut biopsy still like a percutaneous? What am I talking about? Sorry. The true cut biopsy I was talking about is a percutaneous true cut biopsy for lymphoma, not a surgical true cut biopsy. So what you may be thinking of is that we go in to do the surgery and we see the lesion, and we use the true cut needle that fires, gives a trigger that fires, that you may see being done on liver lesions or other things. No, I don't mean that. I mean a true cut biopsy percutaneously by the radiologist. That's what I mean. So a true cut biopsy percutaneously for lymphoma lesion usually will be enough to give the diagnosis and to give you the type of lymphoma, and then they can treat it with chemotherapy. It's rarely that we need to do a surgical excisional biopsy although not unheard of, but rarely we need to do that. Okay, so I think that's all the questions I kind of got. Yeah, brilliant. Okay, so thank you for staying with me. Thank you for being such a responsive group. I'm very appreciative of that as well. Sorry, we've gone past half an hour. Have an excellent weekend coming up. Stay safe. You'll do fine, and stay healthy while you're doing your exams, and don't get too stressed. We have another session, I think, closer to the exam, like revision week, where, I think all the surgery will give some of the lectures to booster your knowledge a bit more, even more focus on the exam, but I'm sure you'll be okay. So if nothing else, goodbye for now. Okay. All the best. Good luck.
Thank you so much.
Welcome. Bye-bye.